We've got Dr. Nathan Herrmann, and the talk is entitled, Can We Make a Senior's Moment a Bad Memory? And Dr. Herrmann is the Richard Lure Chair in Geriatric Psychiatry at Sunnybrook Health Sciences Centre and the University of Toronto, and is the head of the Division of Geriatric Psychiatry at Sunnybrook Health Sciences Centre. He's also a professor of psychiatry in the Faculty of Medicine at the University of Toronto. And Dr. Herrmann's research focuses on Alzheimer's disease and related disorders, pharmacotherapy, studying treatments for cognitive enhancement, disease modification, and neuropsychiatric symptoms. So please give a warm welcome, and thank you so much.
Thank you very much. Good morning. It's really a pleasure to be here, and I have to admit, I feel a bit like an interloper today. You know, it's like that little annoying guy who crashes the intimate family wedding just so he can get access to the free bar. But I will say that one of the things I've learned in my 30-year career, traveling all over the world, is that there is no big city monopoly on good medical research and excellent medical health innovation. And it's really a pleasure to be here and to crash and learn. So my topic today is, can we make seniors' moment a bad memory? And I do have a bit of disclosures. I work with some of the big pharmaceutical companies. I help them design studies to treat Alzheimer's disease, and we run some of the studies. The vast majority of my research, however, is funded by peer-reviewed funding agencies, which I'll show you and tell you about later. The big drug companies are not interested in my research because I try to repurpose drugs that have been around and off patent for 20 or 30 years. So they really are not pleased with me. So I'm going to start with a little bit of background, and this is hopefully going to be good information for all of you in terms of thinking about aging and what you can do to successfully age. So just a couple of definitions to start. Cognitive impairment, problems with memory, language, orientation, concentration, problem solving, and things like that. Dementia, and this is a big problem because many people in the lay community mix up what the words dementia and Alzheimer's disease mean. Dementia is a group of illnesses that are characterized by loss of cognitive function that's persistent and progressive, and it interferes with activities of daily living. Alzheimer's disease is one specific type of dementia. It makes up 2/3 of all cases of dementia, probably even larger amount when you include the mixed cases. But it is like, talking about the common cold. The common cold has 1,000 different viruses that cause it, but rhinovirus is the most common cause. So dementia is like the common cold. Alzheimer's disease is like rhinovirus. How common is dementia? So we have really excellent data from Canada because we have the Canadian Study of Health and Aging that showed that between 8 and 10% of people over the age of 65 suffer from this illness, 20 to 30% of people over the age of 80, and that tells you right away that aging is the biggest risk factor for developing dementia. About 50 to 60% of people in long-term care institutions, it's actually probably much higher than that, and at least 200,000 people in Canada will be diagnosed today with Alzheimer's disease. So what are the causes of dementia? Again, Alzheimer's disease number one. I'm going to talk a little bit more about that in a minute. But there's vascular dementia, dementia caused by small strokes or large strokes or hardening of the arteries, atherosclerosis, cerebrovascular disease. Small number of individuals will have this very unusual form of disease that takes up a lot of work for those of us in geriatric psychiatry because it involves a lot of behavioral manifestations rather than cognitive impairment. Dementia with Lewy bodies, which is that terrible combination between what looks like Parkinson's disease and what looks like Alzheimer's disease, all mixed up into a much worse illness because these guys have a lot of visual hallucinations. Dementia with Parkinson's disease, alcoholic dementia, and then a whole other list of smaller, less common causes. So what is Alzheimer's disease? As I mentioned, at least 2/3 of all dementias occurs in mid to late life, has a variable course. It can be anywhere from 2 to 15 years. When I started my career, we talked about people with Alzheimer's disease living 6 to 8 years on average after diagnosis. And now I'm seeing people that are living 15 and up to 20 years with the illness, and that's probably for a number of reasons. One, because we're diagnosing the disease much earlier in the course than we did 20 and 30 years ago, and also because we have better care for them. But it is a progressive illness, and death is usually due to the physical deterioration. These people eventually begin to forget how to walk, and they end up being bedbound and develop all the kinds of medical complications that are associated with being bedbound. And then about 1 to 2%, very small number of these individuals, very rare families that have familial Alzheimer's disease, where you see 50% of individuals in every single generation have the illness, and it's an autosomal dominant inheritance pattern. So this is the Alzheimer's Society 10 early warning signs. This is great, very worthwhile sharing with the public because it really gives a nice picture of what the illness looks like. So it talks about memory loss that affects daily functionings, difficulty with familiar day-to-day tasks, problems with language, disorientation to time and place, problems with judgment, abstract thinking, manifesting as misplacing things in daily life, changes in mood and behavior, changes in personality, and loss of initiative. And that last one's very, very important because I focus a lot of my research on apathy, as I will tell you about later. So this is what the normal brain looks like. Don't forget about the colors. The colors mean absolutely nothing. This is what the normal brain looks like, nice and plump. And this is what the Alzheimer's disease with these peaks and valleys. And it's the valleys that you're concerned about because it means that brain tissue has died. There is a continuum between what we call normal cognitive aging, and unfortunately, the older we get, there are things that happen with the way we think and process. We tend to slow down cognitively, but our memories still remain very good, and in fact, if we look at what we call crystallized intelligence actually increases as we get older. Then there's subjective cognitive impairment. These are people that are concerned about their memory, like more concerned about it than sort of the average person. But when you test them, there's no evidence that they have actual cognitive deficits. This is a condition that we're learning more and more about. It may be a harbinger of dementia. These people do have an increased risk of developing neurodegenerative disorders than people that are not overly concerned about their memory. Mild cognitive impairment, you can already test them and determine that they have cognitive deficits, although their activities of daily living are completely intact. Earlier mild dementia is when you develop deficits in your activities of daily living. And of course, we have problems first with instrumental activities of daily living, like using the telephone, doing the banking, turning on the television, and the televisions these days are even more complicated than they were in the old days. So these are really good tests of instrumental activities of daily living. And then once we get to moderate dementia, basic activities of daily living are beginning to become impaired. By the time you're severe dementia, you're already having trouble with very, very basic activities. You may have more difficulty with things like feeding yourself, with even walking, and that's when you end up heading to end-stage dementia, where, as I said, you'll be bedbound and essentially mute. So what are the risk factors for developing dementia? I already talked about aging, and just to put some figures onto that, the risk of dementia doubles for every 5 years of life after the age of 65. Yeah, I know, that's kind of scary. But having said that, your risk of developing dementia, if you're over the age of 65, in general, is 1 to 2% per year. Genetics. So even forgetting about familial Alzheimer's disease, if you look at regular or sporadic Alzheimer's disease, your risk is probably 2 to 3 times greater if you have a first-degree relative with Alzheimer's disease than if you don't have a first-degree relative with Alzheimer's disease. So there is an increased risk for having a first-degree relative. Education, the more education you have, the less likely you are to develop Alzheimer's disease, and the more likely you are to develop it if you're going to develop it later in life. Head injury is still a bit questionable, even in these days of what you're hearing in the news every day about CTE, so developing dementia as a result of chronic multiple head trauma. There's still a bit of a debate, really, about how important head injury is, but we generally feel that at least a head injury with loss of consciousness, plus or minus the ApoE gene, increases your risk of developing dementia. Depression, very interesting thing. If you've had a depression at any time in your life, but particularly in late life after the age of 65, you are at very high risk of developing Alzheimer's disease and other dementias. All the vascular risk factors that increase the risk of heart attack and stroke increase the risk of Alzheimer's disease. So high blood pressure, high blood sugar, cholesterol, obesity, smoking, and physical inactivity. And then there's the question about moderate alcohol intake. And again, there is some evidence that there's a U-shaped curve, whereas teetotalers have a very high risk, and then heavy drinkers have a very high risk, and that people that have moderate alcohol intake are sort of at the lowest risk. Because of my background as a geriatric psychiatrist, I do not recommend the use of alcohol to protect you from developing Alzheimer's disease. So, how can we prevent dementia? Or is it an inevitable consequence of aging in the Western world? And the answer is it's not. So let me tell you what doesn't work. And the answer is drugs don't work. Nothing you take by mouth in the form of a pill will help you delay the onset of dementia, reduce the risk, or slow the decline. It does not work. And drug companies have spent billions and billions and billions of dollars over the last 20 years to find drugs that will delay disease progression or that will delay the onset of the illness. So nothing works. And there's nothing on the horizon, meaning there will be nothing on the market within the next 5 years that will be able to delay the progression of Alzheimer's disease or delay its onset. Natural health products also, despite what you're going to read on the internet, they do not work. There is no evidence that these work. And these include things, well-known things like ginkgo, omega-3 fatty acids, and I've done research on omega-3 fatty acids, and then these other interesting things like coconut oil and goji berry. They really don't work. When my patients ask me about them, I say, you want to try? Go ahead. They're likely to be safe, but they're not likely to help. So what does work? And the answer is it's the hard things. It's a brain-healthy lifestyle. So what's a brain-healthy lifestyle? First of all, as I mentioned, education is protective. So make sure you keep your kids in school for as long as possible. But if you're an adult, you continue to learn. Wear a bike helmet. And in this area, you wear a bike helmet and you wear a helmet when you ski. And protect your brain when you're involved in activities that there's potential for brain injury. Optimize hearing and vision. Increasingly good information every year that hearing is intimately related to cognitive decline and worsening cognitive impairment in people that have dementia. So we want to make sure we optimize hearing and vision. Make sure your family doctor is managing your vascular risk factors, the ones I mentioned before, like obesity, hypertension, diabetes, hyperlipidemia, and smoking. Okay, so what really works? If I had to say the one thing that I think is most important to protect you from developing dementia, it's physical exercise. So this is the really hard part. And I give all my patients an exercise prescription. And I tell them you need to be doing, based on the research, a minimum of 150 minutes a week. And you can divide it any way you like. If you want to do one session of 150, that's fine. If you want to do 3 sessions of 50 minutes or 5 sessions of 30 minutes, it doesn't matter, as long as you're doing a minimum of 150 minutes. And you need to be doing both resistance type exercises as well as cardiovascular type exercises. And the reason for that, as I'll show you in a few minutes, is the suggestion in the research that they may be working in 2 different ways. So I recommend, do your walking, do your swimming, do your bike riding, but also go to an exercise class, do yoga, lift some weights. Those are both really important. I also tell them that there's reasonably good information based on research that there's a dose response, so that the more you do, the better off you are. Mentally stimulating activities, things like crosswords, Sudoku, socializing, conversation, courses, learning a new language. My colleagues at Baycrest showed quite nicely that learning a new language is actually a very, very powerful intervention to help reduce cognitive decline. Another set of my colleagues have also shown that ballroom dancing, learning how to do ballroom dancing, works very nicely, because that, I guess, combines both learning with physical exercise and social engagement. Cognitive remediation. So cognitive remediation are the things that you're finding on the internet these days, like Lumosity. And many of my patients ask about Lumosity because it's available free online. And what I tell them is that, first of all, there is no single cognitive remediation program, despite what you read on the internet, despite what you hear in the news, there is no single cognitive remediation program that has proven consistently to be better than any other cognitive remediation program. The key is to find a program that you enjoy and that you'll keep at. So, for example, one of the big studies that was done on Lumosity showed that while you can improve your scores on Lumosity, it doesn't generalize to any of your activities of daily living. So it doesn't really help show that you've got better memory in terms of your day-to-day life. And that's a big problem with a lot of the other cognitive mediation programs. But I still say it's better than doing nothing, and it is exercising your brain. Mediterranean type diet, less red meat, more fish, vegetables, legumes, nuts, especially walnuts and almonds, and using olive oil as much as possible. So here's some proof that this kind of stuff works. And the first I'm going to tell you about is the PREDIMED study. This was an amazing study, a randomized control trial with several thousand people of the Mediterranean type diet. And what they did in this, interestingly, study is that they had you either have a handful of walnuts or almonds every day or drink 2 to 3 ounces of olive oil. Ugh. Yeah, I know. I don't know how they managed to get people to do that. But in the end, they showed that after an average of 6.5 years, subjects who used this type of Mediterranean diet had a 27% lower risk of developing mild cognitive impairment and a 36% lower risk of developing dementia. Remarkably effective intervention. Here's another really good example of how this stuff works. This is the FINGER study from Scandinavia, 2-year long, actually from Finland. A 2-year-long randomized control trial of multi-domain intervention. So this means the investigators really didn't know what component of the brain healthy lifestyle works, so they said, we'll throw everything at them. And they looked at diet, exercise, cognitive training, vascular risk monitoring in an at-risk population. And they found that significantly greater improvements in overall cognition scores on and specific measures. Interestingly, not memory, though, but other types of specific cognitive measures, and a 31% greater likelihood of cognitive decline in the controls. So those people who were given information about diet, information about cognitive training, but were not actually put through these training programs. So I just want, I don't want people to get overly panicked about this, the silver tsunami or the rising tide, as the Alzheimer's Society of Canada calls it, because the news is not all that bad. The Framingham results that were published just a couple of years ago showed that the 5-year age and sex-adjusted incident rates of dementia are declining significantly and consistently since the late 1970s. So we're doing something in our communities that are lowering the risk of Alzheimer's disease. The rates of most vascular risk factors are also declining, but they do not completely explain the declining incidence of dementia. So we're still not sure why this is. There must be something about the way we provide healthcare in North America, or maybe specifically in Framingham. But there is something that seems to be working, and maybe this rising tide is going to be stemmed at some point. The other important thing to remember is that, and this is a bit of a good news, bad news kind of thing. If we can find an intervention that delays the onset of dementia by 5 years, we're going to cut the prevalence of dementia in half. Now, that sounds really good, but what that means is that you're going to live long enough to die of something else. But again, because we know of the morbidity and the suffering associated with dementia, maybe it's better to die of a heart attack when you're 80 than to die after 10 years of being disabled by Alzheimer's disease. Okay, so since this is a research and innovation conference, I'm going to show you some neat, innovative research stuff. And this is my lab at Sunnybrook. This is our clinical neuropharmacology laboratory. This is my co-director, Krista Langto. She's a PhD clinical pharmacologist. And I think that we've worked so well together for the last quarter of a century because she provides the science and I tell her what's important from a clinical perspective. So we have had funding from a number of very important and generous agencies like the Canadian Institute of Health and Research, Health Research, the National Institute of Health from the United States, and very importantly for us most recently is the Alzheimer's Disease Drug Discovery Foundation in the US. So the goals of our lab are to optimize the pharmacotherapy of cognition and neuropsychiatric symptoms in dementia, but also in other medical illnesses. We have a very large research group that are focused on looking at patients with coronary artery disease. And we know that people with coronary artery disease, if you've had a myocardial infarction or if you've had congestive heart failure, you are at very high risk of having cognitive impairment and you are at higher risk of developing Alzheimer's disease and other types of vascular dementia. Similarly, stroke, the rates of cognitive impairment after stroke And the rates of depression and anxiety are very, very high. So these are illnesses that we're focusing on, trying to improve cognitive function as well as neuropsychiatric symptoms. We are mixing clinical trials using a lot of repurposed drugs, as I'll show you about in a moment, with searching for biomarkers and to help us understand why some people with Alzheimer's disease become depressed and some people don't. Why some people with stroke develop anxiety symptoms and some people don't. Why some people with coronary artery disease develop cognitive impairment and some people don't. So we're trying to find out why some people have a protection against these kind of neuropsychiatric symptoms and others don't. So here's a smorgasbord of some of my recent research. So this was a publication from last year where we have looked at the largest collection of studies that focus on inflammation. So you know that with Alzheimer's disease, you've all heard about the pathology being related to this protein called amyloid as well as tau. Amyloid and tau, amyloid and tau. That's all you hear. But 25 years of therapeutic research targeting amyloid and tau has done absolutely nothing. Every single trial has failed. So we believe we need to start looking at other therapeutic targets. And what we showed in this study is that there is very consistent research that shows that a number of inflammatory markers are very significantly elevated in the brains of patients with Alzheimer's disease. And we also found, interestingly, one inflammatory cytokine was very strongly correlated with disease progression. And why is that important? So first of all, the first part's important because now we have another target. Rather than amyloid and tau, we can look at inflammatory markers and see if we can develop targets or develop treatments that reduce these inflammatory markers. But the last point that I made about finding this one inflammatory marker that correlates with outcome is because you think about the kinds of outcomes we use in these clinical trials for Alzheimer's disease, things like the mini mental state examination or the ADAS-Cog or other cognitive measures. These are pretty insensitive to change overall. If we had a biochemical marker, a blood test that declined as we treated people, that might show to us that there is more promise to this particular treatment. So we were pretty excited about this paper. Okay, I've spent my last 20 years looking at a drug that kids take, and that's Ritalin. About 20 years ago, we were sitting down and talking about some of the biggest problems that caregivers face when they treat patients with Alzheimer's disease. And we said, you know, apathy, lack of motivation, lack of initiative, the person who wants to sit in a chair all day and do absolutely nothing, the person who will not do his bathing and feeding and dressing, even though he or she still has the cognitive abilities to do it. That is an important behavioral target to treat. And so we did a number of studies to show that the amounts of dopamine in the brain are decreased in patients with Alzheimer's disease and apathy. And so that led us to say, well, what drugs do we have that increase dopamine in the brain? And one of these was methylphenidate. And so we did a very small randomized placebo-controlled trial that showed that this drug looks very promising. We did a second, this would be called a phase 2A study that looked at a much larger patient sample. This was in 60 individuals, randomized placebo-controlled trial that showed the drug works. And now finally, we're in the middle of our third study. This is a large phase 3 study with 250 patients. We're halfway through recruitment. And hopefully within the next year, we'll be able to present our results. And this may become a standard of treatment for patients with Alzheimer's disease as a symptomatic treatment of not only apathy, but of cognitive impairment. In the second study, we were able to demonstrate that certain measures of cognitive function also improved with the methylphenidate, not just the apathy. So grass for granny. This is obviously, ripped from the headlines from the last 24 hours with the approval of recreational marijuana in Canada. So we became, about 5 years ago, we became interested in whether cannabinoids might be helpful at treating agitation and aggression in patients with Alzheimer's disease. This is a very difficult area to treat. The drugs that we have that are available are very dangerous, and they're not particularly effective. So we wondered about what kind of literature was out there, and we've done 2 review articles. We published the first review article in the area, and we've just published in March the second updated article. And I can tell you that there is virtually no good randomized placebo-controlled trial using any type of cannabinoid to treat agitation and aggression. So we said, okay, fine. So if it's not out there, we're going to do the work. And we did a randomized placebo-controlled trial that we are going to present the results of next month at the Alzheimer's Association International Conference in Chicago. The results, unfortunately, are embargoed, so I cannot give you them. But I am smiling as I go to bed every night. Keep your eye on the news in 1 month from now when they start talking about the results from the conference, because I can tell you there ain't going to be a lot of positive studies that are going to be presented at the conference.
How did you fund that study?
This was funded by the Alzheimer's Society of Canada as well as the Alzheimer's Discovery Foundation. So it was funded by two very good peer-reviewed funding agencies. Okay, very quickly. So this is another meta-analysis that we did looking at the effect of exercise on brain-derived neurotrophic factor. This is a chemical in the brain that actually causes brain cells to grow, even in late life. And what we found in this particular study, again, very briefly, is that you can increase BDNF through exercise, but it looks like it's the resistance training that actually increases BDNF, as opposed to cardiovascular exercise, which probably increases cerebral blood flow. So that's why I said you need to do both kinds of exercise. This I'll tell you very briefly. As I said, we're looking for ways to be able to characterize people that improve versus people that don't improve. And this was an example of our coronary artery disease patients. We did brain scans on all of them, and then we looked to see what markers in the brain show that may predict who is going to get better with exercise versus who is not going to get better with exercise. Lithium builds bigger brains. So this is another meta-analysis that we showed that in patients that are treated with lithium carbonate, which is the standard treatment to treat bipolar disorder or manic depressive illness, patients' brains actually grow after they're treated with lithium. So we wondered whether we could use lithium to treat patients that have had a stroke and increase brain size as well. And that is also currently in press, and so I can't tell you the results. I'm not smiling as much for this one. Can heart surgery improve memories? This is another recent publication that we did. And this looks at a very interesting surgical procedure called transcatheter aortic valve implantation, or TAVI. TAVI is the new wonder child of cardiology and cardiovascular surgery, because what it does, it replaces surgical aortic valve replacement, where they had to cut your sternum open and tear your chest apart and take the heart out and put in the new valve. In TAVI, they replace the aortic valve through a femoral catheter, just like an angiogram is done, just like an angioplasty is done. Remarkable, remarkable surgery. So you can imagine, because it's such a remarkable surgery, they started to use TAVI on the worst patients, the oldest, most frail, most multi-morbidity patients who couldn't tolerate surgical valve replacement. And what they found is that it was remarkably safe, remarkably effective. And so we like this patient population because we obviously expected them to have a lot of cognitive deficits, a lot of depression, a lot of anxiety. So we began studying them. And again, I'm not going to tell you about the studies we did, but we did this as part of our preparation for the study. We did a meta-analysis of the studies that looked at cognitive impairment before and after TAVI surgery. And what we basically found is that there is no change in cognition whatsoever. When you look at people pre-TAVI and then 6 and 12 months after TAVI, there is no change in cognitive function, so people don't get any worse. And in fact, 3 months later, if you look at the 3-month mark, their cognition actually improves a bit. And that's likely because they're feeling better physically, they have more energy, they can participate more in the testing rather than a direct effect on cognitive function. But the good news, as I said, is that it's completely protective of cognitive abilities. So we thought that was also important. And I think that's it. Good. I'm done.